Hello, I'm Dan Hilleman, and this is a continuation of the sequence of lectures that are part of the Advanced Critical Care elective course. And today I'm going to talk about a topic that primarily involves the issue of bleeding in critical care patients. And the topic title is Complications of Drugs Affecting Hemostasis. But it's kind of I guess, for a better lack of a term, somewhat of a hodgepodge of different issues revolving around what to do for that patient that's bleeding, whether it's secondary to trauma or whether it's drug-induced. How do we minimize bleeding complications in the critical care setting? So anyway, it's a bit different in that it doesn't lend itself to a simple set of objectives. We're going to be talking about a variety of topics, but I think that if you end up working particularly in a critical care setting, this is an issue that is a major issue. It's something that you're going to deal with on a fairly routine basis. So again, just to remind you, if you are only using the audio feed for listening to this, I would ask that you open your PowerPoint presentation to the section on complications of drugs affecting hemostasis, and I will be referring to slide numbers as we move through the PowerPoint presentation. So obviously slide 1 is the title slide, so we could move to slide 2. Just some general principles of bleeding. Healthy individuals can lose approximately 30% of their blood volume without the need for transfusion. Tachycardia, mild hypotension are not indications for transfusion. Generally, in patients that have lost small quantities of blood, less than a third, volume can be replaced with crystalline solutions, normal saline, half normal, or D5 half, whatever, lactated ringers. And the rules of thumb generally are, in terms of transfusions, based on what the hemoglobin values are. So if you have a hemoglobin above 10 grams per deciliter, almost no one would recommend transfusion for that patient. If they're between 7 and 10 grams per deciliter, transfusions may be indicated if there are clinical implications, patients with angina, COPD, etc. And it seems like kind of the magic number is 7 when patients have a hemoglobin of 7 or less. Generally, transfusions are indicated. There are some chronic conditions, patients with chronic kidney disease, where a hemoglobin of 6 may be the threshold at which you would transfuse. And it does, as with any change in vital status, the more rapidly that the change occurs, the more likely clinical manifestations will occur. So chronic blood loss over many months tends to be better tolerated than a rapid drop in hemoglobin over minutes to hours. One point on this slide is there is a way of estimating allowable blood loss. This is typically done in the surgical setting, but it allows one to kind of decide, does the patient need to be transfused? We estimate total blood volume based on patients' weight in kilograms. Typically multiply that by 0.08, and that gives you your total blood volume. The allowable blood loss then is 30% of that. So you take your total blood volume, multiply it by 0.3, and so just as an example, if you have a 70 kilogram person, they would have approximately 5.6 liters of blood pumping through their arteries and veins, or 5,600 milliliters. They could tolerate up to about 1,680 mLs of blood loss before you would need transfusion. And keep in mind that this is generally something that is done in the surgical setting, so the blood loss is very acute. It occurs over an hour or 2 or 3 in the OR suite. So if we could move to slide 3 then, not to go into great detail, but I think it's important that we understand what kinds of blood component therapy is available, where they're used, what they consist of. And so the next couple of slides talk about blood replacement or blood component therapy. Whole blood is rarely used, but may be considered in patients with massive bleeding, during open heart surgery, when there's total blood exchange in a neonate, for instance. But essentially whole blood is just what it says. There's no elements removed. It contains all of the elements that regular blood contains, including red blood cells, white blood cells, plasma, platelets. The platelets may not be very functional, and there may be some deficiencies in clotting factors 5 and 7, but 1 unit of whole blood typically is about 450 ml of volume. Packed red cells basically is where most of the plasma, the free water, if you will, white blood cells and platelets have been removed, and so what you're left with is predominantly red blood cells, and so a unit of packed red cells is typically smaller than whole blood. It's 250 to 300 mLs. The hematocrit of the packed red cell is 75%, and the typical recommendation is that 1 unit of packed red cells will increase your hematocrit by 3% and raise your hemoglobin by 1 gram per deciliter. So generally, packed red cells are indicated for replacement in patients that are anemic. They have low red blood cell counts, they have low hemoglobin, low hematocrit, in chronic and acute blood loss, GI bleeding, trauma, etc. Universal PD packs are essentially the same as packed red cells. They do contain some white blood cells, some plasma, and some platelets. But generally, these are the products that are used for transfusion in infants. And so each PD pack is approximately 100 mLs, and it starts off as 250 to 300 mLs that's divided into 3 individual bags, each containing, again, approximately 100 mLs, and they are specifically indicated for transfusion when you want to raise hemoglobin hematocrit in an infant. Leukocyte-poor red cells and washed red blood cells are for patients that may have immunosuppression. They are patients that may have had solid organ transplant. They've had prior febrile transfusion reactions, patients that are going to need multiple transfusions over a long period of time, patients with leukemia, for instance. But typically, most of the white blood cells have been removed to reduce antigenicity of these products, so they contain very few white cells, very few platelets, very little plasma, and typically the volume then is reduced even further. 1 unit is only 200 to 250 mLs. Washed red blood cells are even more complete in terms of removal of white blood cells. 1 unit is about 300 milliliters, and again, more expensive, but the less risk of antigenicity. And so, the decision to use one of these leukocyte-poor or leukocyte-free products, I think, becomes an individualized decision. If we go to slide 4, then, some additional blood components. Obviously, platelets can be transfused. These generally are pooled from multiple donors, and they're given in terms of, typically you can order a 6-pack, for instance, which would contain platelets from 6 units of blood. They do contain some red cells and white cells, but 1 pack of platelets typically will increase your platelet count by 5,000 to 8,000 total. And so oftentimes it requires multiple packs, and that's why you can order this 6-pack of platelets. Generally, the indications for platelet transfusion are pretty severe, if you will. I mean, they generally don't recommend platelet transfusions until the platelet count is at less than 5 to 10,000 total. At 10 to 30,000, you may consider transfusion of platelets if the patient is at increased risk for bleeding, or less than 50,000 if they're at risk for life-threatening bleeding. And there may be situations where you give platelets prophylactically if patients are going to undergo minor surgery and they have a platelet count less than 20, or major surgery and a platelet count less than 50,000. Generally, platelets are not recommended to be transfused in patients with idiopathic thrombocytopenic purpura or thrombocytopenic thrombotic purpura, because those immune-mediated phenomenon, any platelets that would be transfused, are going to end up getting, deactivated anyway. And so platelet transfusions in those patients generally are limited just to patients that would have a life-threatening bleed, or where they're going to end up going to surgery, and you need a short-term solution to low platelets. A cryoprecipitated antihemophilic factor, or what's called cryo, contains factor 7, factor 13, von Willebrand factor, and fibrinogen. And this is a very small quantity because it's simply clotting factors. So 1 unit is simply 10 mLs of these clotting factors, and really are only indicated in patients with hemophilia A who have a predominant deficiency in clotting factor 7 when the recombinant factor 7 is not available. They can also be used for patients who have von Willebrand's disease, or in other settings where there's low fibrinogen levels. Fresh frozen plasma contains most of the clotting factors, and so 2, 7, 9, 10, 11, 12, 13, and heat labile 5 and 7. Typically these are frozen, obviously, and so it takes about an hour to thaw, and generally the volume is 150 to 250 mLs in a unit if you order a unit of fresh frozen plasma, or if it's single donor pheresis, then it would be 400 to 600 mLs. Generally, fresh frozen plasma is used to reverse clotting disorders, emergency reversal warfarin, where patients receive massive transfusions, more than 5 liters. You want to make sure that they have adequate clotting factors on board. Patients who may be hypoglobulin anemic, although IV immune globulin would be preferred in that setting. Clotting factor replacement when other products are not available, and really should not be used for volume resuscitation. So, this is not going to replace volume, and it's not going to have a big effect in terms of increasing hemoglobin hematocrit. It's simply for patients that are bleeding, where you want to get clotting factors on board in those patients. Slide 5, which continues the table on blood component therapy. A single donor plasma, similar to fresh frozen plasma, but lacks factors 5 and 8. Again, it's frozen. It takes an hour or so to thaw. it's only 150 to 200 mLs per unit. And this is not commonly used, but it could be administered for patients that need routine clotting factor replacement, patients with hemophilia B, or what's called Christmas disease, and occasionally has been used for warfarin reversal in patients that are bleeding. Recombinant factor 7, which is technically called eptigaig alpha, has become somewhat of an intriguing antidote to patients that are suffering major hemorrhage in areas that obviously we can't, put physical pressure on to stop bleeding. So intracranial hemorrhage, patients with retroperitoneal bleeding, there are some anecdotal evidence that recombinant factor 7 may be valuable there, but it is a vitamin K dependent glycoprotein. It increases factors 9 and 10. The doses typically are 90 micrograms per kilogram given over 2 to 5 minutes and repeated at 2-hour intervals for up to 3 doses. Some have suggested that you can give a single dose of 270 mics per kilo, and because it's a recombinant product, it's not collected from donors. There's no risk of infectious transmission. Again, the indications are widely varied, but generally spontaneous or surgical bleeding in hemophiliacs, patients with antibodies against factors 8 and 9, and it's being used in a wide variety of other indications, as I mentioned earlier, intracranial hemorrhage, patients bleeding on warfarin, and with some evidence of success. Factor 8, or what's been called purified antihemophilic factor, comes from pooled plasma, and so there is some infectious risk, hepatitis C, and its only indication is for patients that have factor 8 deficiency, which is typically those folks with hemophilia A. Slide 6 continues the blood component therapy table, and factor 9 concentrate, or what's also been referred to as prothrombin complex concentrate, contains factors 2, 7, 9, and 10. There may be, again, because it comes from pooled plasma, an increased risk of hepatitis, and generally it has the equivalent in terms of clotting factors that's twice that you get with fresh frozen plasma. So it is obviously, as the name implies, concentrated. And technically is indicated only for active bleeding in patients with Christmas disease, which is hemophilia B, patients with factor 9 deficiency, and it's in the guidelines for reversal of warfarin bleeding, and so prothrombin complex concentrate could be considered in that setting. Immune serum globulin, again, would be basically for patients that have immune globulin deficiency, and then it is also used for disease prophylaxis. Albumin, 5%, 25%. It's a colloid volume expander, and I don't think there's a lot of controversy anymore. Albumin generally should not be used for fluid resuscitation, that crystalline solutions are much more effective. So theoretically, the primary indication would be the patient who has hypoalbuminuria. There are still some institutions that put albumin in total parenteral nutrition solutions. There are still probably some burn centers that administer albumin in an attempt to maintain intravascular volume. But again, I think that's a relative uncommon practice. So we're going to switch gears then. We've talked a little bit about what to do for patients that have had bleeding complications and what types of products are available in general to manage those patients, either in terms of replacing clotting factors or in terms of treating anemia. Stress ulcer prophylaxis is a common concern in critically ill patients. We know that patients with stress ulcers develop hemorrhagic gastritis, which can lead to bleeding, which increases their morbidity and mortality. And generally, it's thought that there is a specific stressful event, trauma, surgery, organ failure, sepsis, that puts these patients at increased risk for stress ulcers. The estimate is that in the intensive care unit, between 50 and 100% of truly critically ill patients will develop a stress ulcer, but not all of those patients bleed. It's thought that only one up to about 4% of patients will suffer a significant bleed, but in those that do, that increases their mortality. Now, I think the most important, the most crucial piece of information about most stress ulcer prophylaxis scenarios is that the pathophysiology is not stress-induced increases in acid production, which I think a lot of people have the misconception that you're under stress, you're going to produce more acid in your stomach, you get heartburn over a stressful situation in the real world. But in the critical care setting, the pathophysiology is really hypoxia to the gastric mucosa. So anytime there is hypoperfusion to the gut on a relative basis, then you're at risk for stress ulcer. Having said that, there are a couple of circumstances in which we know that there is an increase in acid production and that it's a local erosion effect. This includes patients with closed head injury, patients who have Cushing's disease, adrenal hyperactivity, patients that are receiving steroids. And in those few settings, it is an increase in acid production that's thought to be responsible. Stress ulcers per se predominantly manifest when they bleed, and so unless there is significant erosion into the gastric mucosa, these are usually asymptomatic. So the key in terms of preventing bleeding in that 1 to 4% of patients is appropriate selection of patients for prophylaxis. We have to identify the high-risk patient and then prevent mucosal erosion and bleeding that could result. Now, indiscriminate use, and I mean indiscriminate in terms of giving everyone a stress ulcer prophylaxis, not only is costly, but we know that there unfortunately is a link between starting preventative ulcer prophylaxis in the hospital and a continuation of that therapy in the outpatient setting. And so long term, patients that have been left on ulcer prophylaxis therapy in populations, we know that there's an increased risk of hip fracture, there's an increased risk of Clostridia difficile infection, and an increased risk of pneumonia. So again, I think that the point is that we would want to selectively prophylax patients who meet certain criteria. So slide 8 lists those criteria, and again, most of these, if you stop and think about the underlying etiology, most of these are patients that would have hypoperfusion to the gut. For instance, patients who have respiratory failure, that would have low O2 saturation, they're not going to be perfusing their guts as well. The amount of delivery of oxygenated blood to the gut is reduced, preferentially in people that have respiratory deficiency, and as a result, that reduction in blood flow leads to a breakdown in the bicarb production, It leads to a breakdown in the protective lining of the stomach, and as a result, these patients can develop erosions and ulceration. So mechanical ventilation, particularly patients where you anticipate that they're going to have to be ventilated for more than 48 hours, is an indication for stress ulcer prophylaxis. Patients who have coagulopathy, which is defined as platelet counts less than 50,000 and INR above 1.5, and a partial thromboplastin time greater than 2 times the normal baseline, should receive stress ulcer prophylaxis. Head injury with a Glasgow score less than 10, 15 is essentially normal, so anything less than 10. Thermal injury involving more than 35% of body surface area, surgery on the liver, hepatic or renal impairment, transplant, multiple trauma with an injury severity score above 16, a spinal cord injury, liver failure because you're not producing clotting factors, history of GI bleed or gastric ulceration in the last year, and then any 2 of the following: an anticipated ICU stay greater than a week, patients that have occult or perhaps even overt bleeding for more than 6 days, and then steroid therapy, again high-dose steroids where the steroid dose equivalent is greater than 250 milligrams of hydrocortisone per day. So these are what I think most would agree are clear indications for stress ulcer prophylaxis, in the critical care setting. Slide 9, I think in terms of which agent is preferred, I imagine that most institutions have adopted proton pump inhibitors as the drugs of choice. Having said that, H2 receptor antagonists, antacids, sucralfate, have all been shown to be effective in terms of preventing stress ulcers. They've all been shown to reduce risk of bleeding against a placebo or no therapy type control. But the reality is there's relatively little comparative data available, showing that one class of drug is clearly better than another. There are some small underpowered studies favoring proton pump inhibitors over H2 receptor antagonists based on GI bleeding. We know that proton pump inhibitors do a better job of maintaining intragastric pH above 4 for a longer period of time over the course of a day. But there really are no hard endpoint comparative trials clearly showing that proton pump inhibitors reduce mortality. So I think it's just a matter of intuitively we know that proton pump inhibitors are more effective than H2 receptor antagonists based on pH and based on, again, some small studies looking at GI bleeding. And as a result, many of these drugs are now generic and they, IV and oral. So I think they've become kind of the standard of practice. Slide 10, we want to talk just for a few minutes about antiplatelet therapy because so many patients, and particularly with cardiac disease, end up receiving aspirin. Almost all patients get aspirin, it seems like, with a history or risk factors for cardiac disease. Many patients end up on dual antiplatelet therapy because they've had a stent placed. And so I think it's important to talk a little bit about risk of bleeding with antiplatelet therapy. I think in general, risk of bleeding with antiplatelet drugs is low. Generalized bleeding generally does not occur unless there's an underlying hemostatic defect. The patient has hemophilia, they may be uremic, or the antiplatelet drugs are being given in combination with anticoagulants. Spontaneous bleeding, if it occurs with an antiplatelet drug, typically occurs at a site of compromised vascular integrity. A patient that has a prior history of stomach ulcers or duodenal ulcer, an arterial puncture after heart cath. But if we have a patient that's on antiplatelet therapy and they have a GI bleed, generally we think that's an indication to check out the gut to see if in fact that they have ulcers, because it's not very common to see GI bleeding with these drugs. It's relatively uncommon. It's tough to get a true estimate of bleeding, but somewhere probably less than 1% per year is the risk of bleeding with antiplatelet therapy. It's not uncommon to see micro quantities of blood loss. We know that aspirin and other antiplatelet drugs do increase the rate at which small quantities of blood loss occur through the GI tract, but major, GI bleeding is relatively uncommon. We know that with aspirin that the GI bleeding risk, GI toxicity, is dose related, from as low as 30 milligrams all the way up to 1,300 milligrams. There appears to be a fairly linear relationship between dose and the risk of GI bleeding. One of the things about aspirin that I think makes it probably more likely to cause GI bleeding than a phenylpiridine antiplatelet drug, for instance, is that it not only has the local irritant effect on gut mucosa, but it does impact platelets, which increase bleeding. It's an antiplatelet drug, irreversible. But what it does that phenylpiridines don't do is that because it works through the cyclooxygenase pathway, ultimately reducing production of thromboxane A2, which is a good thing, it has an effect on intermediate prostaglandin product synthesis, which can reduce blood flow to the gut. So there's a three-tiered effect of aspirin in terms of causing GI bleeding, whereas with phenylpiridines we think that, well, one, their effect on the gastric mucosa is there, but it's probably not as potent as aspirin in terms of irritant effect. And they are obviously antiplatelet, but they don't have that effect on prostaglandin synthesis that aspirin does. And so generally, head-to-head, we think that aspirin probably has a greater risk of GI bleeds than a drug like clopidogrel. I'm not certain about a drug like prasugrel, which is a more potent antiplatelet agent, but it's partially reflected in some of the guidelines that if you have a patient that has a stent that needs dual antiplatelet therapy and also has an indication for anticoagulation like AFib, some of the guidelines, like the PCI guidelines, suggest that you can use clopidogrel and warfarin and drop the aspirin in those patients, particularly if they're at risk for GI bleeding. If we go to slide 11, then estimates of GI bleeds with low-dose aspirin is roughly 1 to 2 events per 1,000 patient years. So again, fairly uncommon. We do know that low-dose aspirin, the baby aspirin, 75 to 80 milligrams a day, reduces GI events by 40% compared to 325 and by 30% compared to 160. Again, some of the guidelines tell us that aspirin should be given at 325 milligrams per day, particularly in the dual antiplatelet regimen following stent implants. But oftentimes physicians will use low-dose aspirin because of the concern. They believe that low-dose aspirin, the baby aspirin, is going to be safer in terms of GI risk. So just something to keep in mind. In terms of some of the other formulations of aspirin, like buffered aspirin and enteric-coated aspirin, there isn't much evidence that these products reduce the risk of GI bleeding. The amount of buffering, the amount of acid inhibition in a buffered aspirin product simply is not enough to reduce the erosive effect of aspirin on the lining of the gut. The enteric formulations may reduce some dyspepsia. We've had patients that tell us that they subjectively prefer enteric-coated aspirin products, but there isn't any evidence that it reduces GI bleeding, oftentimes occurring in the intestine rather than in the stomach. Addition of nonsteroidals, whether it be a COX-selective agent, a COX-2 selective drug, which in the United States, the only one that really, I think, truly qualifies as a COX-2 selective drug is Celebrex, or the non-selective nonsteroidals. You add those to aspirin, you are going to see an increased risk of GI bleeding as well. So there are some things that are recommended in patients that are on long-term aspirin, and especially dual antiplatelet therapy. Proton pump inhibitors, H2 receptor antagonists, and misoprostol have all been added to antiplatelet therapy for ulcer prevention. I think misoprostol as a treatment option has fallen off in terms of popularity. There are some side effects that occur with misoprostol, such as diarrhea, which makes it less less tolerable. And so I think most of the data that we have suggests that proton pump inhibitors are probably the preferred agents in terms of gastroprotection in people that are going to be on antiplatelet therapy. There are a couple of trials that have looked at patients that have had GI bleeds on aspirin, and then the therapeutic question is, should I switch them to Plavix, or should I add a proton pump inhibitor to the aspirin? And the answer to that question is, at least based on these trials, clearly add the proton pump inhibitor. If you look at recurrent bleeds in these patients, and again, this is a special population. These are folks that have already bled on aspirin. But if you look at the rates of recurrent bleeds on aspirin with a proton pump inhibitor, it's very low, less than 1%, compared to Plavix without proton pump inhibitor therapy, which is double digit, at least in one of these studies. So we don't have a lot of evidence of using proton pump inhibitors in patients who previously have not had a GI bleed, although the Cogent trial, which was stopped prematurely, the company that was funding that trial, which was looking at proton pump inhibitor therapy plus dual antiplatelet therapy versus dual antiplatelet therapy alone, the interim results when the trial was stopped were pretty convincing that, one, the proton pump inhibitor did not interfere with the effect of clopidogrel in terms of reducing cardiac events, but it did reduce the number of GI events that occurred. So I think, most of us feel confident that proton pump inhibitors are effective. And if you go to slide 12, this is a treatment algorithm taken from a combined white paper published by American College of Cardiology and the American Gastroenterological Society, talking about where the use of prophylaxis with proton pump inhibitor therapy would be recommended. And so you start with patients who, yes, they need antiplatelet therapy. Do they have GI risk factors? Well, if they have a history of ulcer, complications or ulcer disease. Have they been tested for H. pylori? And so if the answer is they do not have H. pylori, then obviously they're going to need to be prophylaxed. If there's a history of GI bleeding, the patient's on dual antiplatelet therapy, or you're going to add warfarin to either aspirin, clopidogrel, prasugrel, or some combination thereof, then a proton pump inhibitor would be recommended. If they don't have any of those risk factors, but they are over the age of 60, they're taking steroids, or they have a history of dyspepsia or GERD, then they also recommend a proton pump inhibitor. So the reality is, at least in many of the cardiac patients, where we see a fair amount of antiplatelet drug, and particularly dual antiplatelet drug therapy being used, the reality is most of these folks are going to be on a proton pump inhibitor. And I think the reality is that we feel comfortable right now, even though a warning has been added to the package insert of Plavix, that we should avoid omeprazole. There isn't a lot of hard outcome data showing that omeprazole actually interferes with the effectiveness in terms of reducing cardiovascular events. One proton pump inhibitor that has been shown not to interact with Plavix in terms of its antiplatelet effect is pantoprazole. So that may be a potential option for those of you that feel uncomfortable violating or going against what's recommended in the package insert. Slide 13, the IV antiplatelet drugs, glycoprotein 2B3A receptor antagonist. These are the drugs that block the site where fibrin cross-links platelets. This is one of the final steps that occur in formation of platelet plugs in blood clots at the site of endothelial disruption. There are 3 of these drugs currently available. The 2 of them we call small molecule drugs, eptifibatide and tirofiban. And they differ clinically in that they, from ipsiximab, which is a monoclonal antibody, which is a huge molecule, hence the reason we call eptifibatide and tirofiban small molecule drugs. But the small molecule drugs are cleared renally, so they do require dose adjustment in a patient that has renal dysfunction. And their effect on platelets is reversible. So if you shut off the infusion of eptifibatide or tirofiban, the platelets regain function once the blood level of those drugs drops below a certain concentration. The difference with ipsiximab, which is Riapro, is one, it's an irreversible platelet inhibitor. So even though we only give integralin for 12 hours, its antiplatelet effect persists until you have turnover of new platelets, which may be 7 to 10 days. So it's more of an aspirin or thienopyridine-like effect in terms of irreversible platelet dysfunction. The other, I think, and this is an advantage for Riapro, is that it's cleared by reticuloendothelial uptake. So reticulocytes will absorb ipsiximab, the endothelium will absorb ipsiximab, and it's not cleared renally or hepatically. So we don't have to worry about dose adjustment in those patients. I think the thing that has limited Riapro's use is simply the fact that it's a very expensive product. And if you look at the data in terms of PCI, Riapro clearly is probably the best drug that we have, but the magnitude of its advantage in terms of clinical effectiveness probably is not offset by the fact that it's very, very expensive. And the fact that the effect on platelets are irreversible. So There are probably still some institutions that use a fair amount of ReoPro. We do not. We have, for most of our PCI patients, have gone to eptifibatide, which is integralin, and the cost is much more reasonable than abciximab. Now, these drugs cause more bleeding than the oral antiplatelet drugs. I think primarily because, one, they're more potent antiplatelet agents. But I think, secondly, you have to look at the setting where they're used. They're used in patients that are going for PCI, who are also getting aspirin and Plavix or prasugrel. They're getting heparin, and so they're being combined with a number of other antithrombotic drugs in a setting where you're puncturing an arterial artery. And that's where most of the bleeding occurs, is at the site where you've done either the radial or femoral arterial stick. It's uncommon to see spontaneous hemorrhage occur, although it's been reported. And it's really extremely rare to see intracranial hemorrhage in patients that are going for PCI, despite the fact they're on aspirin, Plavix, heparin, and a glycoprotein 2B3A receptor antagonist. Now, having said that, patients that are at risk for bleeding, that you know going in have low platelet counts, that have maybe a high Proton or high partial thromboplastin time, that's a setting where bivalirudin may be a better anticoagulant in PCI than using heparin plus one of the glycoprotein 2B3A receptor antagonists. Now, slide 14 lists some of the contraindications to the glycoprotein 2B3A receptor antagonists, and this is taken right out of the package insert. And I'm not going to go through it, and you can read this on your own. You know, most of these contraindications, again, are package insert. You know, they're conditions that obviously will increase the risk of hemorrhage if you administer one of these drugs intravenously. And so it becomes a judgment call. You know, severe uncontrolled hypertension, if we lower the blood pressure with nitroglycerin, can we then give this patient IV integralin? And I think the answer is probably yes. You know, the patient had gotten dextran. I mean, we don't use dextran much anymore, but you know, dextran's just an antiplatelet drug, and there probably isn't much data using dextran along with a glycoprotein 2B3A receptor antagonist. But again, I think some of these, even though they are contraindications in the package insert, some of these are going to be judgment calls. Clearly, a patient with active internal bleeding is probably not going to be in the cath lab unless it's an emergent situation. And you may have to deal with the GI bleed before you can go to the cath lab. So anyway, you can look at these and read these as well as I can. But I think you have to use your judgment as to whether, you know, a platelet count less than 100,000 really contraindicates the use of integralin in a patient that needs a drug-eluting stent, or would you consider bivalirudin that may have a slightly lower risk of bleeding? You know, and I can't answer that for you. So, slide 15, then what about anticoagulant therapy? And we're talking primarily here about one, the oral anticoagulant, the only one that's still available, which is the vitamin K antagonist warfarin. But we'll also talk a little bit about managing bleeding with heparin and with low molecular weight heparin. Obviously, with warfarin, the major complication is bleeding. It is a vitamin K antagonist, and it does remain the only oral anticoagulant that's available in the United States. Now, there are some anti-factor 10 and some direct thrombin inhibitors that are going to be coming onto the market, we think probably later this year, later in 2010, but maybe 2011. Dibigatran or dabigatran has been approved in Canada, primarily for post-knee and post-hip DVT prophylaxis, but also for treating patients with AFib as an alternative to warfarin. So those are the kinds of drugs that may be coming. But for right now, we're still dealing with warfarin as our primary chronic anticoagulant. The risk of bleeding with warfarin is really linked to a number of factors. If you look at well-controlled patients in terms of those that have their INR in range, the excess risk of major bleeding is about 3% over patients that don't take warfarin. So 1% in the general population of patients with cardiac disease compared to about 1.3% in patients who are taking warfarin. Intracranial hemorrhage much lower. We think it's about 0.1% overall. In patients on warfarin, that increases to about 0.3%. So overall, the risk of major bleeding with warfarin, the excess risk of major bleeding is somewhere between 0.3 to 0.5% per year. That's over and above what you would see in the general population, and increases the risk of intracranial hemorrhage by about 0.2%, 0.2%, which is 2 per 1,000 patients. So it's still an issue that we have to deal with, but it's not, again, something that is what I guess I would call common. And the risk factors, and these are the things that we can do as healthcare providers to make sure that our patients don't bleed. One is the intensity of anticoagulation, and with warfarin, it's the calculated value of the INR. We actually, the test that's done to measure the INR is the prothrombin time. I prefer to use the prothrombin time when we first start warfarin. It actually changes more readily, and at least initially, than the INR does. But ultimately, for long-term management, it's the INR that predicts bleeding. The higher the INR, above the therapeutic range, the higher the risk of bleeding. Certain patient characteristics increase bleeding, concomitant drug use, and then length of therapy. So we'll talk about each of these risk factors on slide 16. Intensity of anticoagulant effect. We know that major bleeding, when your INR is between 2 and 3, is half of that rate if the INR is above 3. For every increase in the INR of 1, the risk of intracranial hemorrhage doubles. And this is particularly when you get above 3. The threshold for an independent risk factor for major bleeding is an INR above 4.5. Now, others, I think, will say differently. I personally feel that generally, unless the INR is at 6, the risk of bleeding is not substantially increased. But the evidence, and this is from the American College of Chest Physicians, they have a guideline that talks about the use of antithrombotic therapy. Their evidence suggests that if the INR is above 4.5, bleeding is increased, and it's an independent risk factor for bleeding. So the other issue with the INR, and this has to do with the way that warfarin works, is that it's not just the most current INR that predicts bleeding, but it's actually the last 2 INRs. So the current INR and the one that's done previously were predictive of bleeding. The interesting thing is that the third INR removed from the current situation, the second last, if you will, INR, was not predictive. So this suggests that the window for the relationship between INR and bleeding is relatively short. Most patients, when you first discharge them and they're in an outpatient setting, are going to have their INRs drawn twice a week until they're stabilized. Once they're stabilized, then it may only be once a month. So we're talking about, in some of these studies looking at bleeding, it was the current INR and the INR that was there a month ago that are the best predictors of bleeding. So I think this tells me is that if you have an INR certainly that's above 4.5, you need to make appropriate changes in therapy before you get to the next INR, and you're going to do that next INR more frequently than 30 days later. You're going to probably bring the patient back within a week, certainly, and maybe even less than that. So the INR is the most important independent risk factor for bleeding, especially intracranial hemorrhage. And that doesn't matter what the indication for anticoagulation is. And when the INR, again, is above 4, above 5, then that risk increases exponentially. So slide 17, what about patient characteristics? Well, age has been shown to be a risk factor for bleeding. And 75 appears to be an important point at which, above that age, patients have an increased risk of bleeding when they're on warfarin. When they're above the age of 85, then there's actually an even greater risk of bleeding compared to patients that are 70 to 74 years of age. So those above 85, when their INRs are above 3.5, they have a 2.5-fold increased risk of intracranial hemorrhage compared to patients who are in their 70s who have that higher INR. We do know, though, that when the INR is therapeutic, that excess risk of bleeding is only 1.3-fold higher than the general age-matched population. There are 3 risk factors that have been associated with major hemorrhage, associated with age, and that is, 1, people greater than 80 years of age, lack of appropriate education about disease process and management of warfarin, and polypharmacy, drug interactions. Those are the 3 most important risk factors for bleeding risk in the elderly. So, I think the point is, we do see an awful lot of patients where physicians say, this is a patient that's at high risk for falls, they're 75 years of age, we're going to withhold warfarin therapy. And I'm not certain that age alone should be a contraindication to warfarin therapy. What needs to be assessed, I think, is the whole patient. Is this an individual that will be compliant with instructions, that has the mobility to have their INR checked, that can follow instructions, that isn't confused, that can understand the reason for the anticoagulation and how it impacts their lifestyle in terms of diet, etc. So I don't think age should be, a hard and fast contraindication. It's just one of the important variables that one needs to consider when we're using warfarin. Now, there are some comorbidities that also increase the risk of bleeding. Hypertension, particularly poorly controlled, long-standing hypertension, renal failure, cancer, diabetes, stroke, prior stroke or CVA, alcoholism, and liver disease. Liver disease, you're not making clotting factors, so you're going to have an exaggerated response. We also know that there are some genetic interactions, and there are commercially available genetic tests to help guide selection of therapy doses of warfarin. And there are a couple of different types of genetic polymorphisms. One is that there are patients that we know that are deficient in 2C9, both the 2 and 3 allele of 2C9. So they don't metabolize warfarin as well, and so they end up with basically a higher INR on a usual dose. So they're at increased risk for high INRs and bleeding. So they end up with excessive dosing as a result of the fact that they're not metabolizing the warfarin. Patients that have a deficiency in vitamin K oxide reductase complex tend to be warfarin resistant. They need very high doses. of warfarin and may not have much response at all. So I think there's controversy, and I'm not going to choose sides here, but there are some experts that have fallen in line and said, yes, we need to start doing the genetic testing for patients that we're going to treat long-term with warfarin. Others feel that because you have the Proton and INRs that can be done so readily with finger stick and are now being done in the home setting oftentimes, that the genetic tests are not that important. But I'm going to leave it to you to figure out which route you would take if it comes down to your decision as to whether you would use one of these genetic tests. But I think you need to be aware that they exist, they're available, and they may help some patients, particularly those that where you're giving 8-9 milligrams a day and very little movement in their INR. You might want to see if they have that deficiency in the vitamin K oxide reductase complex. Slide 18 talks about drug interactions, if you will, concomitant drugs that will increase your risk of bleeding with warfarin. Adding aspirin or other antiplatelet drugs to warfarin doubles the risk of intracranial hemorrhage. And so most of the guidelines tell us that if you have a patient who has a thromboembolic event on warfarin and they're at an INR of 2, 2.5, it's probably better to intensify, increase the INR, than to add antiplatelet therapy to the warfarin. Major bleeding when you add aspirin to warfarin. Study in patients that had atrial fibrillation found that 19% of patients that had aspirin added to warfarin, that 19% had aspirin added to warfarin, and that major bleeds increased from 1.3% on warfarin alone to 1.9% just in 90 days. So there's a significant increase in the risk of major hemorrhage when you add aspirin to warfarin, most of it GI bleeding. There are other trials that have looked at this combination, and again, the odds ratio of major hemorrhage is anywhere from probably about 2.5-fold in some studies, and this were in elderly post-MI survivors. Other studies suggest about a 65% increased risk. Others about a 2-fold increased risk of GI bleeding. So again, anytime you add antiplatelet therapy to warfarin, I think one, you have to be aware that there's an increased risk for bleeding. Adding a proton pump inhibitor to that combination will reduce that risk of GI bleeding. And so just have to be aware. I mean, there are patients obviously that have gotten stents that need dual antiplatelet therapy that also have AFib. I guess the question is, what poison do you pick? A GI bleed because you're on triple therapy, or if you withhold the warfarin, you end up with an increased risk of stroke, which is disabling in most patients. Either they die or end up with permanent disability. Or if you restrict your dual antiplatelet therapy, let's say you only choose one antiplatelet drug, the risk of stent thrombosis is then increased. And so many of the cardiologists that I work with tell me that of those three outcomes, GI bleeding, stent thrombosis, and an embolic stroke, which would you prefer to experience? Well, my answer is none, but I think realistically the GI bleed probably would be the outcome that if you had to pick, again, your poison, that's what you would do. One of the more disturbing studies to come out, and unfortunately I'm not certain, I think I was troubled when this was published. There was a nested case control study. It claims trial looking at insurance claims where they looked at a variety of concomitant therapies added to warfarin and found that acetaminophen increased the risk of patients who had INRs above 6, and this held up after multivariate adjustment for other variables. And so they felt that in fact acetaminophen increased the risk of developing an INR of 6, which ultimately would lead to an increased risk of adverse bleeding events. In healthy volunteers that have received Tylenol, acetaminophen, there is an increase of the INR. When you add it to warfarin, the increase was 1.2 compared to a placebo, which was only 0.37. We know that in population studies, acetaminophen plus warfarin increases the GI bleeding compared to warfarin alone. So I think all this tells us is that, if you still, when you look at your options for patients who are on warfarin that have headaches, fever, pain, what are your choices? And I think Tylenol or acetaminophen remains probably our best choice, because if we look at, on slide 19, the traditional nonsteroidals that have antiplatelet effect, whereas Tylenol does not. Tylenol does not have anti-inflammatory properties either. But diclofenac, ibuprofen, naproxen, these drugs can substantially increase the INR and do so in almost half of the patients that are taking warfarin. So again, the question is, you have a patient that needs, that has severe osteoarthritis in a hip. Tylenol may not cut it. It may not be, managing their pain effectively. So, what do? Do you risk adding a nonsteroidal? Do you consider a narcotic like a tramadol or even an oxycodone or hydrocodone, with the attendant problems that presents? We do know that non-selective nonsteroidals increase the risk of bleeding, not just with warfarin, but when you add them to antiplatelet drugs. But a threefold increase in GI bleed rate when you add them to warfarin. COX-2 selective drugs were brought to the market specifically to avoid the increased risk of GI bleeding. But what we found was that they also then tended to increase the risk of cardiovascular events. And so, obviously Vioxx taken off the market, Bextra taken off the market because of those cardiovascular complications. So we're left with Celebrex, which, is COX-2 selective. But it is somewhat controversial whether even the COX-2 selective drug is going to reduce the risk of GI bleeding when you add it to warfarin. So, there are no easy answers here. Again, I think if you're dealing with minor aches and pains, Tylenol should still be the first drug we reach for. Talking about more severe pain, then you've got some issues that have to be dealt with. Drug interactions with warfarin, remember that warfarin is metabolized, or it comes commercially as an S and R enantiomer. So it's a stereoisomer. The S enantiomer is 5 times more potent in terms of its effect on vitamin K oxide reductase. So it's 5 times more potent as an anticoagulant compared to the R enantiomer. The S enantiomer is metabolized by 2C9, whereas the R enantiomer is metabolized by 3A4. So drugs that substantially increase the risk of bleeding when you combine them with warfarin are drugs that typically affect 2C9. Sulfentrazone, phenylbutazone, metronidazole, Bactrim, amiodarone. There are others. I recommend that if you are working with patients on warfarin, find a good reference resource that has a complete list of drug interactions. Don't commit this just to what you can remember. Always check a reference. One thing I will tell you is that the R-enantiomer, those drugs that inhibit 3A4, cimetidine, for instance, over the counter, generally is going to have a relatively modest effect on increasing the INR in a patient on warfarin. I'd still prefer to see the patient take a ranitidine or a famotidine over the counter as opposed to cimetidine, but the magnitude of the change in INR with 3A4 inhibitors specifically who are on warfarin are certainly less severe. Those interactions are less severe than interactions with drugs that affect 2C9 and the S enantiomer. So, slide 20, just to comment about duration of therapy, and the take-home message here is that most bleeding, the risk, is greatest early in the course of therapy when you're making dose adjustments, where you may be overshooting the INR. And so the evidence suggests the first month of treatment, the risk of major hemorrhage is about 3% during that first month. And that after that time, the risk of major hemorrhage then drops. So for the remaining months in the first year, the risk of major hemorrhage is less than 1% per month. It's about 0.8%. And after you get patients stabilized for a year, then that risk drops to what we already know is the major risk difference compared to no treatment, which is just 0.3%. So the point is that, careful attention to checking INRs early is key to appropriate management. Most warfarin clinics and what physician offices should do when you have a patient discharged from the hospital on warfarin and they're not stable, they're seen twice a week, Monday, Thursday, Tuesday, Friday. You're checking INRs at least twice a week. And most patients that discontinue warfarin therapy for bleeding tend to do that early during the course of therapy. Slide 21 is taken right from the American College of Chest Physician guidelines for antithrombotic therapy. I'm not going to read through this, but this is the recommendation. If you're monitoring a patient on warfarin and their INR comes back elevated, this is the recommendations for what you should do. So generally, there are patients who have high INRs that are not bleeding. And some of these folks may have INRs that are above 9. And in those patients, administering vitamin K may be a reasonable part of the management strategy. The only thing to keep in mind is that if you give vitamin K at sufficient doses, and vitamin K should only be administered intravenously or orally. The sub-Q and IM routes are not very effective, and some even wonder how effective the oral administration of vitamin K is. But the point is, if you give enough vitamin K, you will induce warfarin resistance. And if the patient's truly at risk for clots and you induce warfarin resistance, then you may need an alternate form of anticoagulation until the warfarin begins to get therapeutic again. But for those patients who are not bleeding, who have high INRs, typically you can hold warfarin doses or consider giving vitamin K as an antagonist. Obviously, in patients that are bleeding, patients that have serious bleeding at any INR, or who have life-threatening bleeding, then you're going to obviously hold your warfarin therapy. You're going to give vitamin K, typically IV, and you may need fresh frozen plasma. You may need prothrombin complex concentrate, recombinant factor 7. It just depends on the urgency and severity of the bleeding. So you have a number of options in patients that are bleeding. But obviously, these are folks that have to be hospitalized. And again, on this slide, the last point is that vitamin K should be given orally rather than subcutaneously. That is a grade 1A recommendation according to these experts. So, slide 22, just a couple of words about what to do for patients who are on heparin products and bleed. We know that heparin increases the risk of hemorrhage, and that if you add aspirin to heparin, you are going to have an increased risk of bleeding, although this is something that we do 100 times a day in our cardiac patients. We know that adding heparin to lytics, even though it's a class 1 recommendation, doubles the risk of bleeding. Again, the intensity of therapy, the duration of therapy, concomitant administration of other drugs, comorbidities of patients, all need to be considered when you have patients on heparin. The nice thing about unfractionated heparin is that it's a short-acting drug. You start it, and the effect in terms of anticoagulation is relatively immediate. You shut it off, and most of the anticoagulant effect is dissipated within an hour or so. Low molecular weight heparin, most of the data suggests that it causes less bleeding than unfractionated heparin, but I think that's probably because with unfractionated heparin we see such a wide variation in response because it's a relatively heterogeneous pharmaceutical product. You know, the unfractionated heparin that we use, ranges broadly in terms of potency, and so, when we initiate heparin, we oftentimes end up getting partial thromboplastin times that are unexpected. Patients have essentially an overdose after having been given a standard dose of heparin. So I think the fact that low molecular weight heparin is a much more stable product in terms of pharmacokinetics and therapeutic effect on coagulation, that's part of the reason that there's a lower rate of bleeding in some of the trials where these drugs are given for longer periods of time. The partial thromboplastin time is a good predictor of bleeding. We know in several trials that for patients that have increases in partial thromboplastin time, there's an excess risk of bleeding. In the OASIS 2 trial, for every 10-second increase in the partial thromboplastin time, there was a 7% increased risk of major hemorrhage. That's a pretty astounding number. We know in some of the other cardiac trials that in doses above 1,000 units per hour and bolus doses above 4,000, when lytics were given, that intracranial hemorrhage was increased. So the key, and we mentioned this in the STEMI lecture, that if you use lytics to treat STEMI, the maximum amount of unfractionated heparin that can be administered is 4,000 as a bolus and 1,000 units per hour, regardless of body weight. We know that intermittent injection of heparin, which was done many years ago, increases the risk of bleeding because you're giving, you get a peak and trough effect when you give intermittent IV injection. And also when you give sub-Q heparin, you tend to get some of that peak and trough, although absorption is a little slower than IV. And so, certainly bleeding with sub-Q is less than when you give intermittent IV unfractionated heparin. So heparin, unfractionated heparin, if you're going to give it for systemic anticoagulation, it really should be given by continuous IV infusion. Risk factors for bleeding are pretty similar to those for warfarin, but age, renal failure, obviously recent surgery or trauma, those are folks that obviously are at increased risk of bleeding with heparin. Slide 23, how do we reverse the anticoagulant effect of heparin? Well, for unfractionated heparin, obviously you stop the drug, stop the infusion, hold the order for administration. Protamine is a direct antidote. A milligram is equivalent to roughly 100 units of heparin. Protamine's half-life is relatively short, about 7 minutes. Heparin's half-life is 60 to 90 minutes. So the point is that if you look at administering protamine, you only have to consider the last 2 to 3 hours in terms of the amount of heparin that a patient has received. So just as an example, You have a patient that's receiving 1,250 units per hour of unfractionated heparin, and they bleed. They have a significant drop in hemoglobin. You think that maybe it's a retroperitoneal bleed, and you want to reverse the effect of the heparin immediately. How much protamine would you need to administer? Well, the rough estimate is 30 milligrams. If you look at the last, if you will, 2.5 hours, you've given somewhere around 3,000 units of heparin. You've given 2,500 over the last 2, and then another 675 units. So 30 milligrams of protamine would be sufficient to neutralize 3,000 units of unfractionated heparin. So that is kind of, I think, a ballpark estimate of how much protamine to give. You can monitor your PTT to assess the response to protamine. Patients that have been given large sub-Q doses of unfractionated heparin will continue to absorb the heparin over many hours, and so they may need a protamine infusion. Protamine itself can cause some hypotension and bradycardia, not very common, but it's been reported. So the recommendation is to give the protamine, if you're going to do an infusion, to give it relatively slowly. Patients with a history of allergy to fish or prior exposure to protamine, pre-treat those folks with steroids and antihistamines. Slide 24, what do you do in the patient that's receiving low molecular weight heparin and then has a serious bleed? Well, there's no proven method of reversing low molecular weight heparin, which is predominantly an anti-factor 10 inhibitor or a factor 10 inhibitor, whereas unfractionated heparin is equally potent in terms of effect on factor 2, which is prothrombin, and factor 10. So protamine is only limited when we use it for low molecular weight heparin bleeding. In fact, 2/3 of patients that were bleeding that were given protamine, the protamine had no effect on the bleeding. There is some evidence that recombinant factor 7 was effective in a patient with major hemorrhage who were receiving low molecular weight heparin. If the low molecular weight heparin was given in the last 8 hours, then you can try protamine, and the recommendation is 1 milligram of protamine for every 100 anti-factor 10A units, and 100 anti-factor 10A units equals 1 milligram of enoxaparin, which is the most commonly used low molecular weight heparin. So essentially it's 1 milligram of protamine for every milligram of enoxaparin that's been given over the last 12 hours. You can give a second dose of protamine if you have continued bleeding, and lower doses, probably half, can be given if 8 hours have passed since the last dose of low molecular weight heparin has been administered. Go to slide 25. We want to talk just a minute, and again we're changing gears here, about heparin-induced thrombocytopenia, which is a side effect predominantly associated with unfractionated heparin. Rarely occurs with low molecular weight heparin, but we think that it's an immune-mediated complication of heparin, where heparin induces antibodies that attack platelets, and it's a life and limb threatening complication. And predominantly what the findings are thrombocytopenia. You have low platelet counts because the platelets tend to malfunction and clump together, and when you do a platelet count, the clumps of platelets that are intravascular do not get counted. So you end up with a low platelet count, but these patients tend to clot because the platelets are clumping intravascularly. So the hallmark of HIT, and the most severe complication of HIT, is thrombosis. These patients tend not to bleed, interestingly enough. Even though their platelets are not functioning properly, they are clumping together, and so bleeding is not normally a major issue in these patients. Generally, the immune-mediated HIT, occurs after about 5 to 14 days of continuous heparin therapy, or upon re-exposure if patients have received heparin in the prior 30 days. And the pathogenesis, again, is thought to be related to platelet factor 4, which is stored in platelets, and that the platelet factor 4 heparin complexes stimulate IgG antibody production. These antibodies activate hemostatic activation processes, including platelet activation, aggregation, and enhanced turnover. So there's sustained platelet activation, there's an increase in platelet clearance, and thrombin generation, which leads to thrombocytopenia and thrombosis. Now, the extent of thrombocytopenia is quite variable, but typically you can see greater than a 50% drop in absolute platelet count, with absolute platelet counts of 50 to 70,000, where the normal is 150 to 450,000 per ml, per cubic millimeter. It can occur after as short as 4 days of heparin therapy, especially if there has been a recent exposure. So you could have it on day 1, theoretically, if the patient got heparin 25 days ago, readmitted and get heparin for a second time. And new onset thrombosis is a better predictor of HIT than a low platelet count, because we know that heparin by itself will reduce platelet counts typically 10 to 30,000 without inducing the immune-mediated reaction. That's just the fact that heparin is an antiplatelet drug. And again, I want to emphasize, bleeding typically does not occur in HIT. It's really a prothrombotic condition. So slide 26, diagnosis is really very complicated in that this is really a clinical pathological syndrome. So you have to have clinically evident symptoms and lab confirmation. And the laboratory tests that are done, oftentimes there are false positives. There are antibody detection tests, the enzyme immunoassay, or EIA, or particle gel immunoassay. And then there's a functional or activation assay, which is called the heparin-induced platelet activation test, or serotonin release assay. They're very sensitive to development of platelet factor 4 heparin antibodies. And so oftentimes they're positive, the tests are positive, but the patient actually never develops, the thrombotic conditions, which are what we're trying to prevent. So we end up treating probably more patients for HIT than actually would, in the end, have to be treated. And so generally, if you do both tests, then you can, reduce the amount of false positive diagnoses. There is a diagnostic algorithm, if you will, called the 4 T's, which we're going to look at next. But basically, it's a series of 4 questions that are asked, and then points are assigned depending on the response to those questions. And the highest score that you can have is 8. 0 obviously is the lowest, but patients who score 6 to 8 have a high probability of the immune-mediated HIT, 4 to 5 intermediate, and 3 or less are low in terms of their risk. So slide 27 shows you this 4 T's diagnostic algorithm. And the 4 primary questions are: 1, what is the extent of thrombocytopenia? What is the timing of the fall in platelet count, does the patient develop thrombosis or other sequelae of the condition, and does the patient have other causes for thrombocytopenia? So just to simply walk you through this, if the platelet count drops by more than 50% and the platelet nadir is greater than 20,000, greater than 200,000, then you're looking at 2 points. If the platelet count falls 30 to 50%, then it's 1 point, and if the platelet count is less than a 30% reduction, then no points. Timing, if it's occurred after 5 to 10 days of continuous therapy, or within 1 day in patients that have had exposure to heparin in the prior 30 days, then there's 2 points. And if the history is unclear, the onset occurs after day 10, or it falls 1 day and the exposure was more than a month ago, then they only get 1 point. If the platelet count falls in less than 4 days without prior exposure, then no points are assigned. Presence of thrombotic events, skin necrosis, systemic reactions to IV unfractionated heparin boluses, 2 points. Progressive or recurrent thrombosis, non-necrotizing skin lesions, or suspected thrombosis that isn't proven, it's only 1 point. And if there's no evidence of thrombosis, no points. And then obviously other causes for thrombocytopenia, if there are none apparent, in other words, they haven't gotten any other drugs that cause thrombocytopenia, 2 points. If they're on a drug that may cause thrombocytopenia, but it's uncertain, then they get 1 point. And if they are on aspirin or Plavix or a GP2B3 receptor antagonist, then they get no points because those drugs definitely have been associated with thrombocytopenia. So you end up with 4 questions, anywhere from 0 to 2 points. So again, the maximum is 8, minimum is 0, and I think this is one simple way of deciding what's the likelihood the patient has HIT. And if they have HIT, then they need to be treated because they're at risk for increased thrombosis. So what do? Well, you have to stop all heparin products, obviously. You should not administer low molecular weight heparin because that can actually promote further thrombosis if it should occur. And you have to use a non-heparin anticoagulant. So stopping heparin is not enough to prevent new thrombosis from occurring. And you don't want to give warfarin right away because it can do venous limb gangrene. You can't use low molecular weight heparin. Platelet transfusions are contraindicated because these folks are already have too many platelets that are malfunctioning and clumping and clotting intravascularly. So what we end up with using are predominantly direct thrombin inhibitors, and there are 3 that the FDA has approved specifically for HIT: lepirudin, argatroban, and dinaparoid. Dinaparoid was never marketed in the United States, as far as I know. Fondaparinux and bivalrudin are potentially useful for managing HIT, and bivalrudin or argatroban are often used in patients that need to be anticoagulated that are undergoing cardiac procedures, angiography, PCI. They need dialysis, they need a CABG, where large doses of heparin typically are administered. Again, the downside to using a direct thrombin inhibitor is that, like low molecular weight heparin, we really don't have an easy antidote to administer. If patients should bleed on a direct thrombin inhibitor, it's almost as if you were managing that patient that was bleeding on warfarin. Other than you would not give vitamin K, you'd have to consider fresh frozen plasma, you'd have to consider a prothrombin complex concentrate, perhaps recombinant factor 7. there isn't a great deal of evidence to guide our choices for dealing with direct thrombin inhibitor-induced major hemorrhage. Although we do monitor these drugs using partial thromboplastin times. Generally, a 2 to 2.5-fold increase is considered therapeutic when we use these drugs. Slide 29, drug selection. This is really based on, well, do you have renal impairment? Do you have liver impairment? Do you have multi-organ dysfunction? Or are all you needing is a prophylactic dose to prevent DVT in a patient with a history of HIT? So we'll talk about some of the individual direct thrombin inhibitors, but argatroban, for instance, is predominantly cleared by the liver. So if you have renal failure, argatroban, which is not cleared renally, would be the preferred agent. Bivalirudin and lepirudin have significant, and fondaparinux have significant clearance through the kidney. So those would be poorer choices. Liver impairment, a drug like lepirudin or bivalirudin that are cleared predominantly by the kidney, would be a better choice. Multi-organ dysfunction, I guess none of the agents are really that good. Dinaparide not available in the U.S., but maybe bivalirudin. I don't know. Again, this is adapted from another reference. But you know, somebody with multi-organ failure, you know, then I guess it's tough to know what the best agent to use would be. Prophylaxis of DVT, though, in a patient with a history of HIT, probably the best agent is fondaparinux, 2.5 milligrams per day, given sub-Q as a once-a-day dose, will prevent DVT in patients that cannot take heparin. I've got a couple of slides, slide 30 and so on, that talk about specific pharmacodynamic, pharmacokinetic issues with each of the direct thrombin inhibitors. And I'm not going to take a lot of time to read through these. You can do that on your own. They have recommended doses based on, for instance, lepirudin, which is an irreversible direct thrombin inhibitor. Its half-life is 90 minutes. The range is 1.3 to 3 hours. You monitor it with a PTT. It's cleared predominantly by the kidney, and so mild, moderate, severe renal dysfunction require progressively lower doses. And there are antibodies that are produced in patients that are exposed to lepirudin, and so anaphylactic reactions can occur if you would have to re-administer lepirudin at some additional time down the road. Argatroban is one of the drugs that we use a fair amount for patients with a history of HIT outside of the cath lab, so if they're in the intensive care unit in particular. It's a synthetic monovalent direct thrombin inhibitor that's cleared hepatically, minimal renal clearance. 45-minute half-life. The PTT is the way to monitor these drugs. Stop argatroban and coagulation factors return to normal within 2 to 4 hours. Because they're direct thrombin inhibitors, they will also increase the proton and INR, and so you have to be aware of that when if you plan on putting these patients on warfarin. This drug does increase nitric oxide, and so I'm not certain what the clinical implication of that is, other than some patients may have a slight drop in blood pressure as a result. It is the direct thrombin inhibitor of choice for people with renal insufficiency. In severely ill patients, there's a dose adjustment, assuming they're not perfusing their livers as well. Argatroban is one of the few drugs that came to market but never had a trade name. There's no trade name. It's simply argatroban. Slide 32, bivalirudin is cleaved by thrombin and renally cleared, so it does have to be adjusted for, dose has to be adjusted in patients with renal dysfunction. The anticoagulant effect is reversible. Relatively short half-life, and it is dialyzable. We use bivalirudin predominantly in that patient who tells us they've had an allergy to heparin in the cath lab. You know, in the ICU, patients with hepatic dysfunction, it can be used as a good choice there because ergatroban is predominantly cleared by the liver, whereas bivalirudin is cleared renally. But renal function, obviously you have to make some dose adjustments with bivalirudin. The naproxen, I'm not going to spend any time with. Again, it's technically not a direct thrombin inhibitor. It's what's called a heparinoid derivative, and we think that it's predominantly a factor Xa inhibitor, much like fondaparinux. So not available in the U.S., and so I'm not going to talk about this, and it won't be on any of the testing material. Fondaparinux on slide 34 is an anti-factor Xa inhibitor. It's more specific to factor Xa and has a longer half-life than low molecular weight heparin. You can monitor its anticoagulant effect if your lab does anti-factor Xa levels. The target range is 0.4 to 1 unit per ml. Generally does not affect partial thromboplastin time or INR. And generally we don't recommend this for any indication other than the prophylaxis in patients who tell us they have an allergy to HIT. There are some data in patients with PCI, acute coronary syndrome, the OASIS trial. There's also post-knee and hip prophylaxis recommendations, but it's technically not approved for managing HIT. It does not bind to protamine, so if you have major hemorrhage with fondaparinux, there is some evidence recombinant factor 7A may be the most appropriate antidote. What about long-term vitamin K antagonist therapy or warfarin therapy in a patient who has had HIT? Well, many of these folks have developed HIT because they were on heparin for a good reason. They have an indication for warfarin, AFib, DVT, etc. So many of these folks are going to need long-term anticoagulation therapy. The recommendation is to start warfarin once the platelet count reaches 100,000 per ml and continues to rise. You can start warfarin, obviously, because it works slowly. It works by preventing synthesis of clotting factors. And so your patients are going to be fully anticoagulated on a direct thrombin inhibitor. And what needs to be done, and this is the art, is to taper the direct thrombin inhibitor as your INR becomes more therapeutic. Now the problem is some of the drugs, the direct thrombin inhibitors, increase the INR. So you know, it's empiric oftentimes that you are reducing the dose of direct thrombin inhibitor as you get closer to day 5 of warfarin. You know that you're probably getting close to therapeutic with the warfarin. And it's not uncommon to see an INR above 5 when you're on a direct thrombin inhibitor. So you can't be thrown off by that. You need to continue the warfarin and probably 5 milligrams a day or so for 5 days. You're backing off on your direct thrombin inhibitor. And then, as these are usually short-acting, they will wear off relatively quickly, and you can get a true sense of what your INR is at day 5 or so on warfarin therapy. As I mentioned on slide 36, there are patients that need huge doses of heparin for dialysis, for going on the external extracorporeal membrane oxygenating machine for bypass surgery. And almost all of the direct thrombin inhibitors and naproxen have been used during dialysis, hemodialysis. Leparudin, bivalirudin, and argatroban have been used during CABG surgery. One thing to keep in mind, though, is that obviously the drugs that are cleared renally, the naproxen, bivalirudin, and leparudin, if you would have if you have a patient who's on dialysis even though these drugs get dialyzed, they may not be the best choice because the patients are obviously in renal failure. That's why they're going through dialysis. So it's an issue that they're tough to manage, but I think a lot of folks feel that argatroban, particularly in the dialysis setting, would be the preferred agent. Just a comment about lytic therapy. I'm not going to go through this. We talked about this in the STEMI lecture, but clearly patients that have STEMI where you want to administer lytic therapy, there are absolute and relative contraindications. You need to keep those in mind. Your rate of intracranial hemorrhage with lytic therapy in patients who suffer STEMI should be no more than 1%. If your rate of intracranial hemorrhage is higher than 1%, that would suggest that your process of selecting patients appropriately for lytic therapy may have not been correct. I mean, you may have missed something. And that should trigger an audit of the patients that have suffered the intracranial hemorrhage to see if, in fact, the appropriate steps were taken to rule out patients that should not have received lytic therapy. So that's just kind of an aside comment in terms of quality assurance. But I'm not going to read through these. They're available in the STEMI lecture as well. But it's a judgment call if it's a relative contraindication, whether they can get lytic therapy with these relative contraindications for STEMI. There's also an algorithm that's been developed for managing intracranial hemorrhage once it's occurred in a patient that's received systemic lytic therapy. Obviously, these patients need routine neurochecks when they're getting lytic therapy. Reversing the effect of the lytic, is a possibility. Medical therapy, fresh frozen plasma, cryoprecipitate, platelets. Probably the only thing, obviously stopping other anticoagulants, probably the only thing that has clearly been shown to impact outcome in these patients is emergency neurosurgical evacuation of the intracranial hemorrhage. And so, that is something that needs to be considered right away in a patient that has a neurologic deficit that's just received a systemic lytic agent. But the outcome for most of these folks is dismal. 90% die. The other 10% are permanently disabled because the intracranial hemorrhage is usually fairly substantial and causes massive neurologic deterioration. So you can read through the algorithm, and again, this doesn't happen very often anymore. We don't use a lot of lytics for STEMI, but when it happens, this should be part of the checklist, if you will, in the emergency room in the coronary care unit when you have a patient that you've treated with lytic for STEMI. Now, slide 39, this is important in that if you treat a patient for ischemic stroke with a lytic, the contraindications are different. So they're a bit more restrictive than they are for patients where you're treating with STEMI. Primarily because the risk of intracranial hemorrhage in patients with ischemic or thrombotic stroke is higher than it is in patients with STEMI. So again, I'm not going to read through these, but there are a number of conditions here that are specific to stroke. For instance, a patient that suffers a seizure at the onset of stroke, lytics are contraindicated. Patients that have known bleeding diatheses, there are a little tighter restrictions, absolute contraindications than it is for STEMI. But again, you could read through these. I think it's important that, again, if you treat a lot of stroke patients and you would consider lytic therapy in these folks, there should be a checklist of things that need to be done in managing that patient with ischemic stroke, and this would be part of that protocol or treatment guideline. What are the absolute contraindications to lytic therapy in acute ischemic stroke? There are a few agents that have been used to promote clotting. Other than drugs that have been used to reverse the anticoagulant effect of other agents, other than the blood component products that we talked about, there are some systemic hemostatic agents that have been predominantly developed for other reasons, but we also have figured out that these drugs promote, if you will, clotting, and they can prevent bleeding, particularly in the surgical setting. And that's where most of these systemic hemostatic agents have been developed, and many of them were developed specifically for patients undergoing open heart surgery. So there are some antifibrinolytic drugs, a protonin, tranexamic acid, and epsilon aminocaproic acid, that basically increase the what they do essentially is the opposite of what the lytic agents do. They each work a little bit differently, but the bottom line is that they end up reducing fibrin breakdown and stabilize platelet function. So they actually promote clot formation, and they promote stabilization of clot. They do this typically by reducing plasmin, which leads to fibrin breakdown. Each of them works a little bit differently. The procoagulant drugs, desmopressin, specifically it's a vasopressin 2 receptor agonist, which increases the clotting factor 8 and increases von Willebrand factor, and also increases platelet activation. And then we've already talked about eptigog alpha, which is recombinant factor 7, increases coagulation both via tissue factor and tissue factor independent pathways. So both sides of the clotting cascade. Just a couple of words about these, because at one time, it seemed like there was a lot of use of a protonin in patients having repeat CABG. Patients who've had a prior CABG surgery have higher rates of bleeding, primarily because they end up with a lot of scar tissue. They have a lot of fibrotic changes in the thorax. And when you cut through that scar tissue, there is a lot of vascularity in that tissue, and they end up with greater blood loss. So a protonin was approved, this is slide 41, a protonin was approved to reduce blood loss and to reduce transfusions following bypass graft surgery. But along the way, there was evidence that using a protonin increased renal failure, the risk of heart attack, stroke, and death, and that was occurring more often than with aminocaproic acid or tranexamic acid. And kind of the death knell for a protonin was the BART trial published in 2008, which was multi-center, double-blind, randomized in high-risk CABG patients. They got a protonin, tranexamic acid, or aminocaproic acid. Study was terminated due to an increased risk of 30-day mortality, which was essentially 6% for a protonin and about 4% for the other two profibrinolytic agents. There was more hemorrhage with tranexamic acid and aminocaproic acid. So a protonin did the job. It reduced hemorrhage, but it increased mortality due to MI and cardiogenic shock. And we think that what happened is that because it's a profibrinolytic agent, it increased the risk of clotting in the coronary vascular bed. So a protonin's been withdrawn from the market. So slide 42, what we're left with are tranexamic acid, which originally was approved for administration in patients that had tooth extraction, had hemophilia. The IV dose that's used for surgery is initially a 3 to 10 gram loading dose IV, and that's for the oral tooth extraction and hemophilia. But for patients that are going to go on and have surgery, it's 2 to 7 grams, and then 20 to 250 milligrams an hour as a continuous infusion. It has been shown to be effective in reducing blood loss and transfusions in both CABG and orthopedic surgery, patients who are at high risk for bleeding for whatever reason. We think it's generally similar in efficacy to a proton or aminocaproic acid, although the BART trial didn't show that. I mean, the rates of bleeding were certainly a little higher with tranexamic acid than it was a proton. But we haven't seen the rates of MI and mortality with tranexamic acid, but I think we need to be cognizant that that still can occur. Most of the side effects of tranexamic acid are related to the GI tract. Rash and anaphylaxis has rarely been reported. Retinopathy, again, this would occur because of increased clots in the retinal artery. It's been reported, but again, relatively rare. I think we've taken kind of the glass half full approach to using these drugs for repeat CABGs. Is the risk worth the benefit of reducing the potential for hemorrhage? And I think it has to be an individualized decision. Aminocaproic acid, 10 to 30 grams total dose. The loading is 1 to 15 grams, and then 1 to 2 grams per hour. Remember, we don't have a lot of hard evidence, in CABG patients. Most of our understanding of these drugs comes from that BART trial. So we think it probably works. Aminocaproic acid probably works as well as tranexamic acid, but probably less effective than a proton. Side effects with aminocaproic acid: GI, edema, headache, bradycardia, hypotension, and rare cases of rhabdo. I've seen physicians use this for patients with subarachnoid hemorrhage, thinking that they can stop the bleeding. Some have suggested these could be given to patients that have had serious bleeds with lytics, because they do kind of the opposite of what thrombolytic or fibrinolytic drugs do. Again, not a lot of evidence that they're effective in those settings. It's mostly anecdotal, but you got to remember that those are folks that have very poor outcomes. And so, when you're in that setting and you're thinking, is there anything else that we can try that may save this patient's life, it may be worth a shot to administer tranexamic acid or aminocaproic acid to reverse the effect of the lytic. Desmopressin, primarily used in hemophilia A. We're on slide 44, sorry. Slide 44A, desmopressin. Primarily used for hemophilia A and for patients who have a history of von Willebrand disease during surgery. It's also been used in people undergoing CABG, but less effective than tranexamic acid. Our surgeons have actually used desmopressin. The recommendation is 0.3 mics per kilo as a 20-minute infusion at the start of surgery. Adverse effects: facial flushing, headache, palpitations, hypotension, water retention, hyponatremia, abdominal cramping. None of these are considered deal breakers in the patient going for CABG, because they're put under relatively deep anesthesia. And again, thrombosis is a concern. I mean, with all of these procoagulant drugs, I think we have to be cautious in terms of what is the benefit we expect, what's the bleeding risk, what's the risk of transfusion, and how much of that risk is going to be abated by giving these drugs that can promote intravascular clotting. And that's a tough question, I think, to answer. But our cardiothoracic surgeons still, for repeat CABGs, look at desmopressin, and they may consider tranexamic acid in some of these cases. Eptigog alpha on slide 45 is recombinant factor 7A. Technically, it's indicated for surgery in hemophiliacs. It does correct prolonged INRs, and so it's being used for patients who have severe hemorrhage on warfarin. It's being used off-label in patients that come in with trauma or with surgeries that have gone awry. Apparently not effective in patients that have had liver resection or undergoing liver transplant, where they're not producing clotting factors, or their clotting factor production is diminished. But because it's a recombinant product, it's pretty clean in terms of toxicity, no risk of antigenicity, thrombogenicity, or viral transmission.